the 3rd of January. This is the high risk recurrent and advanced group. Anybody who's in here that is high risk, recurrent, or advanced is very welcome to stay. It does come with a warning that what do they call those warnings? That a health warning that you may hear things you don't want to hear if you're not high risk, recurrent, or advanced, but that doesn't mean you have to leave. So we're very happy to have you. I am looking through quickly, and I don't see anybody, I think, that is new. I think everybody in this, Philip Rocha, have you been with us in this group before?
It's been about a year or maybe 18 months or so.
Okay, but you have been in the group. You have been in the high-risk group before.
Yes, sir. I have, I'll tell you, you can tell me if I qualify or not, but I have 0.096 ultrasensitive PSA. I had my robotic surgery 51 months ago.
You're very welcome to stay. You're maybe recurrent, maybe not. I don't remember talking with you in this group. It may be that you were in Peter Kafka's group, quite possibly. So we can spend a little time with you. Is there anyone else who is new to the group? Okay.
Hello, right. Can you hear me? Can you guys hear me?
Yes, we can. That's Marty Weiss, right?
No, Martin Parada. I'm new to the group. I've never been in this particular section before.
Okay.
Real quickly, my story is I had radiation.
Well, hold your horses. If you're new to the group, we'll give you time.
Thank you.
So, and how about John Garvin? Have you ever been in the group before, Mr. Garvin?
No, I haven't. I'm a first timer as well. Sorry,
That's okay. So, we have Philip Rocha. How do you pronounce your last name? Is it Rocha? Rocha? How do you pronounce it?
Rocha.
Okay.
Yes.
So we have three new guys. I don't think we can probably take more than 3, so we'll get through you 3 guys, and then I will poll whoever's left at the end of the 3 guys to see who needs time today, because I think we're going to use the first hour speaking to these new men. So,
Rick, just a second. I see a neighbor of mine, Jim Dubois, Tucson.
Yes.
And I believe this is probably his first time. I know him.
Jim Dubois has been on here before.
Oh, okay.
Yes.
So, but I didn't realize he was a neighbor of yours, Dennis. But yeah, Jim Dubois has been on here before. So we'll come to Jim. I'm sure he has a question for us. We'll make sure we talk to him when he's back.
This is also my first time here. If you have time for me later.
Mike Marino, I know I've spoken to you before, Mike. I'm sure.
Not in this setting. You might have spoken to me either by email or phone. I have a introductory question.
Bear with me. Let me pull up my notes here, because with my notes I can figure it out. Contacts. Michael Marino. Yeah. I know we talked with you somewhere because you came through Jim Marshall in Australia, not our Jim Marshall. And you have intraductal 3+3. You were seeking a second opinion from Epstein, right?
Yeah, I've already gotten it, and he bumped it up to 4+4.
So he moved you up to a 4+4. So yeah, and you are all right. Well, let's see who we can get through. It so happens we've got somebody else who's facing a similar issue to you, so it would be good to talk to you. And you are at 4+4. You're definitely high risk. Is there anyone else? Winston, have you been on this call before?
I'm just listening in. I manage a group of advanced prostate cancer patients. Hello?
I'm sorry, you manage a group
of advanced prostate cancer survivors, but I'm not advanced, so I'm just here for information. Yeah.
Okay. All right. Well, you're very, very welcome. And Kathleen Kavanaugh, have you been in the group before?
I've sat in once or twice before.
Yes. In this advanced group?
No, on the other group. I was just getting ready to sign out, actually.
Oh, you can stay with pleasure. You're more than welcome to stay if you want to listen to the guys.
Well, thank you.
I didn't. So let me just say this again. Everybody is very welcome to stay. If we can really only handle 3 new people, and we're going to try and squeeze a conversation in with Mike Marino because he has a similar situation to Michael Chandler. And then we'll come back after that. So let me get going here, and we'll move pretty quickly today. We may not be able to take quite as much time as we normally do because obviously it's a big crew with 53 people here. All right, let's start with Philip Rocha. Philip, how old are you? I'm going to ask you a few questions just to whistle through this, and then we'll talk about the situation. How old are you?
56.
56. Okay. And where do you live?
Austin, Texas.
Okay. And when were you first diagnosed?
March 2016.
What was your Gleason score and your PSA at that time?
7.4, and Gleason was 3+4.
Okay. And who were you? What sort of place were you getting treated? Were you at with a local urologist, or were you getting treated at Center of Excellence in Houston, or where were you?
I started locally in Austin, and I didn't know much about cancer, and just went straight to MD Anderson in Houston, and that's where I got treated.
Okay. And who was your surgeon there?
Dr. John Davis.
Okay. And so so when did you have, you mentioned you had surgery, I think. When did you do that?
That was October 12th, 2017.
Right. And what was the result of that surgery? What was your PSA when 6 or 7 weeks later?
It was undetectable.
And that's good. And how long did it stay undetectable for?
I think it was April 2019.
Okay.
That I got a reading.
And from 419 until today, you said it was at 0.096. Is that right?
Yes, sir. So at April 2019, I was 0.021.
Right. So it's gone up in 3 years. It's almost 3 years. It's creeping up to 0.096. When they did the pathology after your radical prostatectomy,
for a while, but then it went off by itself.
Guys, please mute if you're not.
That was actually Fred, Rick. He's having a microphone problem.
Talking, Fred Stiers, please mute. We can hear you. It's not working. Thank you. What was your what was your Gleason score when they did the post pathology?
One of the lesions was changed to 4+3.
So you came out of the surgery as a 4+3.
Yes, sir.
So and since then you've done no treatment, is that right?
That's correct.
Okay. And just a couple more questions. Did you ever have any do you have any cancer in the family?
Yes, sir.
Tell us about it.
So Dad had squamous cell carcinoma, basically understand just to be a skin cancer on his tongue. And his he got treated at MD Anderson. They extended his life for 13 years. He went back because he had a growth behind his lower lip, between the gum and the lower lip. It was like maybe the size of a small raisin. And what they told my dad was that, Mr. Rocha, we gave you that new cancer because of your radiation treatments you had 13 years ago. They said it's very rare, but it does happen. Mm-hmm. So unfortunately, he did not wake up from surgery. So that is that's my dad's.
I'm so sorry.
Story. Well, thank you, sir. Appreciate that.
Yeah. How long ago was that, Philip?
That was about 8 years ago, maybe 9.
And any other cancer in the family?
Well, not conclusively that I can say. So I think that my grandmother on my mom's side had colon cancer, but that that's more 2 or 3 aunts saying that, but I've never seen any records or anything like that.
Yeah. So have you had any genomic testing of any type?
No, sir.
Okay. So I ask that because at this point, it might be worthwhile, because of your father, just to do a germline test to see if you inherited anything. And it's a very simple test, and it's something you should discuss. Colon cancer is a bit of a red flag, and squamous cell also can be a bit of a red flag because it can be associated with BRCA. So probably worth doing. So I think you're probably here to find out, when do I start? What do I do? When do I start treatment? I'm sort of up to around 0.1 now. What do I do? And I'm going to let some of the guys talk to you.
Thank you.
Who would like to Who would like to give Philip some, tell them what they've done when they've seen their cancer start to recur? Because there's quite a few of you in here have been in that situation. Nobody want to speak up?
Well, I think it's time for a scan. I don't believe Philip has had any scans since he had his prostatectomy. Is that right?
Yes, sir, that's correct.
Have you spoken to your doctors about getting any scans to see if they can identify where the lesions are that are causing the PSA to rise?
I did today, actually, visited with the radiation oncologist. He said that my PSA was very low, that more than likely we wouldn't be able to detect anything, but I'm very open to hear y'all's thoughts and advice. I'd prefer not to do radiation, but if that's the only option, you know, I guess that's what I'll have to do. But no, sir, I haven't done any scans.
So Len, his PSA is 0.096 right now.
Oh, sorry, I thought it was 0.96.
No, 0.096.
Got it. Okay.
Yep.
Philip,
So
Philip, this is Peter. My PSA is at 0.09. And oddly enough, I met with my oncologist a couple of weeks ago, and he wanted me to do a scan. And I said, wait a minute, you know, my PSA is not high enough. He said, oh, I think it'll show something. And this is a pretty reputable oncologist. And so I called today because I called Clarify, and they said, no, we don't want anybody doing it unless you're at least 1.0.
Okay.
I doubt something would show up. I think you might have to wait a little longer. I wouldn't panic. I mean, several years, it's moving pretty slowly.
And Len, correct me if I'm wrong, but is it still common? I don't know. Now the word just flew right out of my head, but aren't they looking for like at least a 0.2 before they're talking about a chemical recurrence?
Yeah, absolutely. I misunderstood. I thought he said 0.96, not 0.096. At that low PSA, I'm not sure there's any urgency to do anything. Just keep monitoring it.
Well, Philip, I didn't have the exact same track as you, but our ages were very similar. I was 51 when I was diagnosed and had it I had it on October 7th, 2015. I had my prostatectomy, and then turned 52 shortly after that. However, my recurrence was immediate. I mean, at 12 weeks, I already had a 1.6 PSA. But I did the radiation. I had to wait a while. I had to get my continence back from the surgery, and they did put me on androgen deprivation therapy. And I took a little while of rehabilitation before I had the surgery, which I had in basically around June of 2016. So 8 months after my surgery. And I did have side effects from the radiation also. But as Peter said, in your case, if you're doing an ultra sensitive and it's only showing a 0.09, if something's happening, it's happening incredibly slow, and they're not even recognizing it as a chemical recurrence yet. At least that was the common, doctor's ideas back when I was looking at this recurrence. So. And anybody has, I was going to say, anybody that has anything more recent information, feel free to chime in. And as Peter said, apparently if something's happening, it's happening really slow. So, and even the scans that these guys are talking about, they want you to have a higher PSA before they want to do the scan. So is Joe on? I see he's muted and his camera's off, but
you know what
Joe
that
had
number is?
Joe had a PSMA scan that the VA was doing as a clinical trial, and I think they wanted. Joe, did they say they wanted a particular PSA before your scan? I mean, he was willing to give it to me just because of the clinical trial. I have an undetectable PSA.
In my case, they were just looking at the fact that I had an elevated PSA with no treatment, and they wanted to do that for comparative purposes. So my PSA was running just a little over 10.
Okay.
So
as Len said, Philip, I think maybe they're looking for something a little higher.
Yes, let me come in here because I'm also cognitive of time with so many people and today and so many new people. The first thing is it may be recurring, Philip, but the best news is that whatever's happening is happening very slowly with you, even though you're young, and we recognize you're young. So probably the best thing to be doing is to be testing regularly. How often are you getting PSA tests right now?
Every 4 months.
So you might want to shorten that up a little bit. If you've got the constitution to do that, you might want to shorten that up to every 2 or 3 months and keep a very, very close eye on how it's moving. You know, even if it jumps a little, don't be that worried because the tests aren't super accurate. Make sure you're always getting the test at the same place so that they're comparable. But keep an eye. Where was the radiation oncologist that you spoke to?
It's a let me see if I can find. I think I left it in my car, but it's a very large.
Is it a local person?
It's statewide. No, it's not MD Anderson. It's statewide, okay. And
so let me say I would suggest if you can to try and maintain your treatment at MD Anderson. We haven't seen great treatment in Austin.
Okay.
And it's enough to give me concern. And since you're in the MD Anderson system, at least let them monitor you until you're ready for treatment. Once you're ready for treatment, if you do need radiation, you can talk to them about who they work with and who they can work with locally, so you don't have to be going all the way to Houston. It's too far. But my recommendation to you from a navigation standpoint would be stick with them, and they have some very good radiation oncologists at MD Anderson. Stephen Frank is one that I know who's really good, but they've got a whole bunch of them. And, you know, I would be talking to Dr. Davis and following up with him and let him tell you when the time is right. That would be my recommendation to you. And in the meantime, watch it carefully and get your mutations, your germline mutations tested just in case you're carrying anything, because it will indicate what sort of treatment to do.
Is there a specific test you recommend for the genomic testing?
No, I would either ask Dr. Davis, ask your GP, tell your GP you want to do germline testing because your dad had cancer, you have cancer, and you're wondering, you know, there's a possibility it could be BRCA related, both could be BRCA related. You may have had an aunt who had colon cancer, it could be Lynch syndrome. You can remember that, Lynch syndrome related, and just ask them. If they give you a hard time, you can get it yourself. It's not that expensive. You can go to somebody like color.com. I think it's $250. There's other people, Invite and a bunch of other people, but I would recommend you do that. And you know, you're welcome to keep coming back here as often as you like, and bounce stuff off of us.
I appreciate it very, very much.
Okay. Anybody else have any other final words they'd like to leave with Philip?
Yeah, just me, Rick. I'd just like to go ahead, Bill.
I was just going to say one more thing. My genitourinary oncologist, back when I started going on just like regular checks versus ongoing treatment, actually said, don't bother with the ultra sensitive PSA because you might see these small movements and it just plays with your mind, and we're not going to do anything until it reaches a certain level anyway. That's just my 2 cents. And he's a good guy. I like him still. So, okay, go ahead, Ken. I'm sorry.
No worries. I just wanted to first of all say, Phil, you're more than welcome to attend the under 60, advanced prostate cancer group that happens every second Thursday of the month. And if Rick has your email, we'll include you in the list. And we talk about everything but kind of treatments. But every now and then treatments do pop in there. So definitely stick with, as Rick stated, try to get, keep your connection at MD Anderson. And by all means, you can always, send, get your labs done close to home and send the information via either email or I just take a picture of it and send it through my own email to my doctor there. So I don't have to run back and forth and see my doctor at MD Anderson, but I keep them informed. So good luck, and hopefully it continues to move slow.
I appreciate everyone. Could someone repeat the name of the radiation doctor at MD Anderson?
Frank, F-R-A-N-K is one. Stephen Frank, but I don't know. Ken, who else is worth considering at MD Anderson for radiation?
Unfortunately, Rick, I did not have radiation at MD Anderson, so I don't have a list of names.
Okay. Jim Ward, do you have any? Are you still with us, Jim? I know you were for the presentation. Are you with us? Anybody else have any other names? I can't remember off the top of my head, Philip. But Stephen Frank is definitely a good name. I'd have to go and I'd have to go look in. Unfortunately, I can't do it right now whilst I'm moderating. But come on back. And right now, I wouldn't even go straight to a RO. You don't need an RO. Go back to Dr. Davis. That's your starting point. Keep working with him, and then when he thinks you're ready for radiation, he'll tell you, and he'll refer you, and you can say, well, let me also talk to some people. You'll come back, and we'll tell you what we know about the radiation oncologists there.
I appreciate
now,
everyone.
You are in the. Right. I see you're in you are in our database. And you are signed up for the Speaking Freely. So, excuse me, you are signed up for Speaking Freely, and also you are now signed up for the under 60. So you'll get the reminder for that. And come join us in the under 60 and in the Speaking Freely group, and keep coming back here, and we'll do our best for you. I've got to move along.
Thank you.
Pleasure. The next person that we'll talk to is I didn't write the new people down. John Garvin and Martin, and then John Garvin, and then we'll go to Mike Marino. Martin, what was your last name?
Yeah, can you hear me?
We can.
Yeah, last name is Parada. I'm sorry I didn't put it up there.
Don't worry. And are you signed up on our database? Do we have your email?
Not sure. I think I am, but I'm really not sure. I might have.
Okay. Okay. Well, stick your email. Put your email in the chat window. Everybody know where the chat window is? The little there's a little question box, a speech box, speech circle, bubble in the top right-hand corner. Click on that and put it in there, or send it to me, rd@ancan.org. We'll make sure you get a reminder for the next meeting. How old are you, Martin?
71.
Okay, and where'd you live, sir?
New Jersey. You know where New Jersey is?
I've heard of it. We've got a few of your compatriots on this call. What year were you first diagnosed?
Oh, diagnosed 20. I was about 18 months ago. Oh, geez. So we're talking about 2020.
Okay.
June.
And what was your Gleason score when you were diagnosed, and your PSA level?
Well, PSA was off the chart. I was 29 PSA, and my Gleason was 8 or 9, something like that. 8 plus 9, something like that. Very high.
Was it 4 plus 4 or 4 plus 5?
I really don't know. They just said between 8 and 9, something like that.
Okay, well, that sounds to me like you're a 4 plus 5, but this is important information. And 29 is not so high. But since we've got guys on this call who are diagnosed with PSAs of 3,000,
wow,
29 in the scheme of things is not so bad. So don't worry. That's where were you treated, and what type of doctor did you see right at the beginning?
Primarily urologist, who's with a big practice called New Jersey Urology, and they have they're kind of vertically organized, horizontally organized. They have their own cancer treatment center. New Jersey Urology does.
Yeah, we know them. We've had other guys that have been there, so we got
them. So I did my radio. He put me on. He put me on right away. He put me on ADT with Eligard, and then he got me started with radiation. 48 radiation treatments with him, and then after that, my PSA stayed down for about 8 months.
Let me ask you a question. Yeah. Let me ask you a question. Did they do any scans before you started the ADT, and what were the result of those scans?
I had lymph nodes, basically, that lit up on the CT scan.
Okay, so you were diagnosed, in effect, you were diagnosed metastatic.
Yes.
And with lymph node involvement, correct?
Yes, indeed.
And did they just give you Eligard, or did they give you another drug with that Eligard?
Well, they gave me Prolia for the bones, but nothing else for the cancer.
They didn't. Okay.
No.
And what happened? Tell us what happened to your PSA.
Well, it stayed low after the radiation, and while on the Eligard, it got very low, went back down to like a 2 or something like that, at 1.7, and then a couple of months ago, it shot back up dramatically, up to about 20. And
so let's slow down a little bit, okay? When did you do this? You did this in 2020, right?
I had the radiation treatments in 2020, end of 2020, beginning of 2021.
Right. And your PSA never got below about 1.7?
No.
And the doctor didn't talk to you about any other drugs?
Not at that time.
No. And he just watched you for a while, and has he added any drugs since the ADT and the Prolia that he was giving you?
Yes, because when my PSA went back up to 20, he put me on enzalutamide.
Okay, and when was that? When did it get to 20? When did he do that?
That was about 3 months ago, 4 months ago.
But he saw it rising and he waited until it got to 20. And is this the radiation oncologist you're seeing, or who's
No, it's a urologist. He didn't see it rising. It went from 1.7 up to 20 in between, within the space of a month or two.
I mean, literally in the space of a month or two? I mean,
yes, within the space of maybe 2 months. Within the space of maybe 2 months, it was down low, and then it shot up within 2 months.
Okay. Yeah. Yeah, I mean, the big problem is that the fact that it never got below 1.7 is a big red flag, and they shouldn't have been waiting for it to shoot up to 20. So, have you had any genetic testing? Is there any cancer in your family?
No, I just had foundation. I had promise color, and I had foundation also. They just finished it. I had the promise test, the color, and I just finished the foundation medicine.
Yes, you had. Okay, well, that's good. So, did your urologist order the foundation medicine?
Yeah, I had that. Yes.
And was that a blood test?
Yes, and a tissue one, both.
Okay, so the tissue that they took was from where and when?
Well, from the original biopsy back in, back in 2020. Yeah.
So they used tissue from the original biopsy. Now, do you know with FMI, are they doing a tissue? Are they doing a tissue analysis, or are they doing a blood analysis?
They did both. They did both.
They did both.
Yes.
Okay. All right. Well, that's good that they did both. Have you had the results?
Yes. They said there's no mutations of any note. That's what they said with respect to all of them.
Okay. Well, it's good that at least he redeems himself. So, the guys, we'll throw it out to the guys right now. But the big thing that you're going to hear repeatedly over the next 10 minutes is that you got to get yourself treated in the right place.
Yeah, and by the way, after I've been on the enzalutamide for a couple of months, and my PSAs have gone back down. My last PSA was back down to 1.7.
Okay, so your PSA, so he added the enzalutamide, and when did you start on that enzalutamide?
A couple of months ago, maybe 2-3 months ago.
Okay, and now you're back down to 1.7.
Yes.
So you responded well to the The big problem here, I mean, there's a couple of issues. One is on the treatment that you're on, your PSA should be lower than that. So what we need to be doing is finding out where your metastasis is. Has anybody talked to you about doing more advanced scans?
Not yet. I know that there's a PSMA gallium out there. I know there's a cyclovine out there.
Yeah. I'm not sure what they're waiting for, especially since your PSA was as high as 20. I mean, they should be doing those scans yesterday, and we should be trying to figure out where that cancer is And whilst you are responding to the enzalutamide, which is good, it would be better if they were also seeing whether the cancer is in a place where they could shoot at it and try and keep it low, because you may still be oligometastatic. We don't know.
And what kind of scan do you recommend?
Well, we don't recommend. We can tell you what the best scan is.
Go ahead.
And the best scan is we believe right now is probably that the Pylarify scan 18F,
right?
DCF PYL. That's probably a little bit better than the gallium scans, and it's readily available. But more important than that, I would say, and again, this isn't medical advice. This is navigation. You're not being treated in the right place, and you're not being treated by the right doctor. And that's why you're dealing with some of the issues you're dealing with right now, because some of this should have been done ages ago. Some of these, the scanning should have been done when you never went down below 1.7. And the enzalutamide or abiraterone or similar should have been introduced a while back. That's what we would have seen in other people. So you need to be, you might be on the right treatment now, but it's not enough. It's not enough of the right treatment. What we would say is this: get yourself a really good genitourinary medical oncologist. Okay. Now,
how about Dr. Narayan at University of Pennsylvania?
Well, I would say you don't need to go to University of Pennsylvania. You got plenty of good choices in Manhattan. Unless you have a desire. What part of New Jersey are you? Or unless you're in
I'm South Jersey. I'm closer to Philadelphia.
Ah, okay. That's why. Okay, well, he's okay at UPenn. You know what? Let me ask Joe Gallo, because we often refer to Fox Chase, but we do know the guys. Joe, what's your opinion of him versus say your guy?
He would definitely be closer and going to see a quality guy if he goes sees Guinnessman at Fox Chase, because Fox Chase, the facility is in Northeast Philadelphia.
Okay, and what's the name of the doctor?
Guinnessman, Gen.
G-E-Y.
Go ahead.
G-E-Y-N-I-S-M-A-N.
G-E-Y-N-I-S-M-A-N.
Y-N-I-S-M-A-N. Guinnessman.
Daniel
He's very
Guinnessman.
good.
I got it, Daniel Guinnessman. I got it.
And
yeah, and he's Joe's doc. The fellow over at UPenn, UPenn has only recently become an NCCN center. Not that it's bad, but Joe, I mean, what's your take on UPenn versus Fox Chase, Abramson versus Fox Chase?
Well, I don't know enough to tell you about UPenn other than they are a good facility. But if I had to flip a coin, like I said, he's coming out of Central Jersey, and North Jersey, New Jersey urology is like right off of 95. He could get an appointment and get over to Fox Chase a lot easier than trying to go into Center City.
Okay, gotcha.
If you need your help in trying to make the connection, you can get a hold of me, joeg at AnCan.org. Okay. And,
okay, I could probably look him up. joeg at AnCan.org. Okay.
Yeah. You should be able to find him in the directory, but he's definitely a good guy. He knows his stuff, and he's doing okay by me so far.
Okay, thank you guys. I appreciate it.
Anybody else want to say anything to Martin? "48 of you on here and nobody else wants to say anything to him?" It's okay.
Everybody is thinking what you've already told him, and that is he needs to get a different doctor. I know a little bit about NJU, and I can tell you that they're predominantly a radiation facility. So, and the docs that are associated with it, that's their inclination, and he needs something a little more than that at the moment.
Have we explained to him that he needs a genitourinary medical oncologist? Have we told him that yet?
Yes.
I hope we told him
did,
that.
David. Yeah.
And Dr. Ganesian is a genitourinary medical oncologist?
Yes, Guinnessman. Yep.
Yes.
Guinnessman. Sorry. Okay. Thank you.
Yeah. Yeah.
How's
So,
the new
I
drug
think
hitting you now?
What's
Sorry?
that, John?
I was wondering how the new drug is hitting you. It's only
Oh,
been a couple
the enzalutamide? I'm doing pretty good on it.
yeah. How you doing on it so far?
Yeah, I'm doing pretty good. I mean, I got some hot flashes, of course, and, some fatigue, but otherwise I'm doing pretty well on it.
Good.
Are you exercising?
Well, I'm not, because I have arthritis in my back and my hips, and it really hurts me to move around. I mean, I try to walk around some, maybe do some stationary bike, but really not a lot. So,
Does the stationary bike hurt you? Can you do the stationary bike even on a recumbent?
Not for long. I'm not on a recumbent now, but it's hard. It's not for long.
I think one of the things you've got to do, Martin, is get with a trainer and work out an exercise regime, because it is absolutely key. It is going to be so important.
Okay.
You can't stress the importance of exercise enough. And, most of us at your age have arthritis and pains, and we've got to figure out a way to get around to work with it. But you've got to do some weight exercise. Lifting weights shouldn't bother you with the arthritis. You should be able to come up with a regime for that. And as far as aerobic is concerned, try and find something that works for the aerobic, even if it's a stationary bike, if it's walking on a treadmill, whatever it is. Even with starting in small doses, it is so important. We cannot stress how important it is.
Thank you. I appreciate that. Thank you.
Okay. Listen, come back to us. Tell us how you do with Guinnessman.
Okay, I will.
And make sure we've got your email, please, so
Okay.
we can add you, and you'll get we meet every single week. How did you find us?
Oh, how did I find you? Really, just maybe through zero or US2.
Okay.
Just plunking around, really, just looking around, reading some stuff, and I came across the AnCan name.
Okay. Yeah, and and it's really, really important too that you get that PSMA scan, or even an Axumin scan will work for you at 1.7. But you need an accurate scan, because we want to make sure that what you think is arthritis is in fact arthritis.
Got you.
You get what I'm saying?
I do.
Okay. So come back, we'll help you. We've got loads of knowledge here.
Obviously, I'm seeing that.
Yeah. Okay. I'm going to move on to John Garvin. you know the routine now, John, so I'm going to whistle through with you. How old are you, sir?
67. By the way,
Okay.
I'm in Toronto, Canada. I'm here. The notice sent out by Winston. I belong to the Toronto group there, the Warriors group, and through advisory, he notified me about this session this evening, and that's why I've joined in.
Fantastic. Okay. And what year were you first diagnosed?
So basically in the late 2018, I started getting elevated PSA to beyond the 4 and was climbing to 5 and referred to urologist. And he monitored me for a while, kind of observed things. And then we did a biopsy in January 2019 where I came back with a 4-3 Gleason, and it was the lesion was identified in the left lower lobe inside the prostate itself through the MRI. In fact, the periods came back a 3, so it was a toss of a coin as to whether it was perceived to be malignant or whether it's benign. Surprisingly enough, I did the biopsy after the MRI, and it confirmed that it was in fact a 7 Gleason on a 4-3 scale.
And what did you do with that? Let me ask you a few questions because we'll move through quicker that way. Did you which institution were you going to Sunny Hills?
Right now, I'm with Princess Margaret Hospital under the care of Dr. Finelli.
Princess Margaret.
Yeah, but
who's your doc?
I was treated. I consulted with Dr. Finelli and a couple of urologists as to what the next step would be when I was diagnosed in basically March of 2019 when we finished scans and so forth. And we decided that I would be a good candidate for HIFU. I don't know how many of you are familiar with it, but that's what I want.
We're familiar with it.
And
so did you do HIFU?
We did do HIFU on April 25th, 2019, under the direction of Dr. Orr then, who was the guy who brought HIFU system to North America, including the U.S. The first versions of it, the Americans were coming to Toronto to do it.
Let me just jump in. I'm sorry to rush you through, but we got a lot of guys, and we're pretty well educated on these systems. We know them, so we don't need you to. We just need to know a little bit about your history. So you did HIFU. Now, had they done any scans? Since you had a 4 in your number, did they do any scans before you did the HIFU?
We didn't do. We only did MRIs. We didn't do any other. We did biopsy and MRI were the two that kind of set us up. For,
they didn't do a bone scan. They didn't do a CT scan.
No, that wasn't done until the recurrence situation.
Okay, because normally in the U.S., if you got a 4, if you're a 4+3, sometimes even with a 3+4, but a 4+3 or higher, they'll always do a bone scan and a CT scan. Usually doesn't show anything, but sometimes it does, like it did with Marty, like with Martin Parada just now, and so he knew up front that he had the lymph node problem.
And now we're on the drop balls on that first episode of treatment through HIFU and the follow-up or the lack of. Go ahead. You can ask the questions.
Let's find out what happened to your PSA after the HIFU.
After the HIFU, unfortunately, I had as a result of the catheter, I picked up a hospital-acquired bacteria that went to UTI and then became full-on sepsis, and I went through 6 weeks of treatment in the summer of 2019. I went through a battle with the sepsis. My PSA was recorded in July of that year, 3 months after, at 5. It never went below 2019.
Hold on a minute. Yeah, we need to. Martin, can you please silence? We're getting a lot of feedback from you. Thank you.
July 2019, it kept staying around the 5 level, 6 level. I kept insisting that something was not right, that it should be dropping. He insisted that I still had 3/4 of a prostate left. That would still indicate levels like that. And it wasn't until, unfortunately, come January of 2020, when I was starting to aggressively ask for scans, we ran into the COVID pandemic, and that kind of deferred a lot of follow-up and treatment. So by the time June 2020 rolled around, I went and did a further follow-up on a PSA, and it was 9.9. And at that point, I got his attention that I needed some significant scanning done, and a MRI was done in July 20th, and it was determined that I had advanced and metastasized in a local fashion into the lymph nodes, as well as there was a presence of an apparent tumor in the mesorectal fat, which remained suspicious for a long time because it could have been a post-mortem situation from the PSA, but nonetheless it was there, and it was a concern which prevented surgery. I was then referred to, hey, I can't help you any further. We need to get you to another team. And that's when Dr. Finelli picked me up again in August of 2020 at Princess Margaret. We did all the CT scans there. I was clearing the bone, and the CT.
Hold on a minute. Hold on a minute. What sort of doctor is Finelli? Is he a surgeon? Is he a radiation oncologist, or is he a medical oncologist?
He's a surgical oncologist. He is head of the team there.
Surgeon.
He
Right.
trained in
Okay.
Cleveland.
So they referred you back to the surgeon, and what did Finelli do?
Well, at that point, we went through to the tumor board after the CT came back, identifying that there was a large mass in the mesorectal fat, as well as the lymph nodes. There were some ductal features in some of the biopsy done in the lymph nodes. And he basically started me on Lupron at that time. And we were going to monitor that, which we did. I did respond to the Lupron to the point where my nadir got to about 4 at its lowest level on the Lupron. We deferred the radiation at that point until actually we were going to remonitor and recalibrate CT scans and bone scans in February, which again came back. And by the way, my PSA at that point had climbed to 6.7. So
Yeah.
it was.
I want to just keep moving, and what we're hearing here. Let me just ask you: did they do any genetic testing, and do you have any cancer in the family?
Genetic testing in December of 2020, and it was determined it was free of anything that was predisposed. I mean, I could read you that the germline was clear.
Okay. So germline was clear, and have they ever sent any samples off for next generation sequencing? Or like Foundation Medicine Canada?
No.
Well, so let me just and have you done any radiation? Have you done any additional radiation yet?
Bring you fast forward to current April, May of 21. I went through 40 sessions of radiation, 8 weeks. First 25 were more enlarged pelvic area to pick up the other zones, and the last 15 were concentrated in the prostate.
We got it, and so you had 48 sessions of IMRT, and where's your PSA right now?
40 sessions. Right now, my current PSA after 6 months post radiation is 0.18.
So now we're looking at the real thing. And I think what guys, if you're listening to this, I think you're seeing one of the big issues about focal treatment. And unfortunately, what happened to John is not untypical of people with more advanced disease who do focal treatment.
Yeah.
Our experience, again, we're not docs, but if it were me, I would never do focal treatment as a 4+3. Might consider it as a 3+4 for much the reasons we've heard. So had they dove in and given more aggressive treatment up front, then we might be seeing this 0.18 right now. Are you, and I know it's difficult and different in Canada, but are you on a secondary hormone drug? Are you on enzalutamide or abiraterone or similar?
Darolutamide, Nubeqa is what I'm on, introduced in May. So I'm on to darolutamide. It's Nubeqa. It's a Bayer product.
Oh, Nubeqa, you're on darolutamide. Great. Has that been a? We've got several men. We've even got men on monotherapy darolutamide in this group. Has the darolutamide been approved then in Canada?
Yes. It's very expensive. It's about $50,000 a year. Thank God I've got some coverage on it. But yes, and I've been on it now, call it 6 months properly.
And so the darolutamide and the Lupron have driven you down to 0.18.
Yes, latest. Yes, I have to test again.
Right. Now, again, I know this is difficult, but I know there are docs available. Who is supervising your treatment? Is it still Finelli?
Well, there's two. Finelli was the main key team member, but Dr. Rahman is my radiation oncologist, who I'll be seeing again next week. He takes care of both the radiation treatment as well as the script for what they call ARAT, the Nubeqa.
So again, we feel very strongly in this group that you need to involve a medical oncologist at this point.
Yeah.
And they're hard to come by in Canada. And, we find that a lot of the surgeons want to run the advanced disease. And frankly, I just don't think they're capable. I don't, because this is why we're seeing the situation that you're in right now. Now, the question is, can you find one? And I know that there are a couple in the area, in the Toronto area. I don't have a name for you offhand.
I appreciate that. Your care is overseen by a control group called the Tumor Board, which has medical oncologists that sit in on those boards.
Right. It is not the same.
Yeah, I hear you.
John, it's not the same. I mean, I've been working for years now with a guy in Niagara Falls, Ontario.
Mm-hmm.
And eventually we got him, and he's now being seen by medical oncologists. Yeah. And you have to do whatever you can to try and get yourself in front of those medical oncologists are on the tumor board. If they know enough to be on the tumor board, they know enough to be your docs.
Yeah.
And the surgeons don't want to, and the radiation oncologists don't want to release you.
Yeah.
And we can't stress strongly enough that they're not the right docs, and that's why you are where you are today.
Let me give you a variable that I'd like to, and I've taken that note, and trust me, I will be following up that aggressively. But let me introduce something else that was found in July, and that is a lesion in the sacrum that detected in the scan done in February there was no, in the bone scan, there was no indication of any lesion in the sacrum. And then in the subsequent scan, the bone verified with the CT and vice versa. They saw some activity there, suspicious activity that hasn't changed in size since the two scans were compared, but haven't indicated any increase in the PSA as a result of the presence of that particular lesion. It was a singular lesion. So I don't know how to, well, we're going to find out soon enough how to interpret.
Yeah, I mean, ideally, you're going to need to let your PSA rise if it does, so that you can get a PSMA scan. I mean, some people will actually come off the drug so that their PSA gets up to above 0.65. And then at that point, you can do a better scan, and you would have a more definitive diagnosis. Otherwise, you're not really, you know, it's tough to know. I mean, short of them doing a biopsy, which they could do, and if they did a biopsy, if they did a bone biopsy right now, and that's what they found, then they could do spot radiation, and spot radiation can be very effective when you don't have many lesions, as you probably know.
Yeah, that's one of the things we did discuss, and the fact that right now they're watching the response to the ADT treatments, and that I've been responding favorably in terms of everything. Every month it's been declining. I've been doing very regular PSAs, even beyond the 3 months, almost a monthly.
So let me just throw it open to the guys, because we've got to still move on, because and it may be interesting to you, because we've got to talk a little bit about, and we're going to talk a little bit about intraductal.
And which I asked you one question about side effects that we're dealing with, notwithstanding the hot flashes and so forth, which I have no problem with. But since I started on Lupron and the added Nubeqa, I've been anemic in the sense that both the hemo and RBCs and everything else have been impacted, and they're consequently offside. Although my hemo has climbed a little bit up to 111 right now. So we did a complete workup on the hematology unit to see whether there was any underlying conditions causing the anemia, and none were found. So they're basically classing it as a reaction to the ADT that's causing this anemia, which has its own side effects, shortness of breath and other things that go with anemia. But is anybody else experiencing that?
Many. So I mean, I'll throw it out, but I mean, I was anemic. I was on for 2.5 years. I was anemic. There's a lot of guys that have been have suffered anemia from being on longer term. How long have you been on the Lupron treatment now? When did you start the Lupron treatment?
Lupron started in September of 2020, so that's about, call it 15 months. I've had 6 injections. The ARAT, the Nubeqa, has been 6 months.
Okay. Len, you think, I mean, it sounds more like the Lupron than the Nubeqa. Are you aware of any issues around anemia from darolutamide?
Well, I've been on it for over 2 years. I do have mild anemia, like 11.8, I believe it is, hemoglobin, 11.8, hematocrit, about 35, 36. But, you know, that was probably brought down by ADT when I was on ADT. So, I mean, there are angiogen receptor androgen receptors in the bone marrow. So clearly, any type of androgen receptor axis drug is going to have an effect on the bone marrow's production of red blood cells. So, yeah, you can't get away from it completely.
So it's not having deficiency. It's pretty well the bone marrow production or lack of. Any drugs that were added to counter that?
To counter the anemia?
Yeah.
But no, there's nothing you can do about that. How low is your hemoglobin?
Well, in our terms, and I guess metric terms, it's 111, we call it here. I got as low as 104. 135 is your baseline lower end. So I'm about 15 points below that. So I'm 111, and the RBC is a 3.6, and the hematocrit was around 3.3. WBC has climbed back up nicely. They were compromised as well. The only thing I'm really offside on, other than that, is the lymphocytes, which are below norm. And maybe that's a result of radiation on the lymph nodes. I'm not quite sure if anybody else had lymphocytes low.
Yeah, I do. My lymphocytes have been chronically low since radiation. They were actually, my baseline was relatively low even before I had prostate cancer. My platelet counts were about 150,000, which is at the bottom end of normal. And then after radiation, they tended to run between about 110 and 120,000, that is.
Okay.
But
one issue,
fighting anemia.
One issue we've got here is making sure that we're talking in the same units, because I know that that the units that John's talking about are not necessarily the units that you're using.
Right. I have no idea. I have no idea how to translate his units to ours.
Factor of 10 in one case, and I'm not sure, but it sounds to me like 111, and you said you're 11 point something.
11.8.
11.8. So you're roughly running a 10 factor on that. So
you can get comparable with where you are, John. And here's a man who's been on monotherapy. So Len hasn't been using an LHRH drug for 20 months now, Len, 22 months?
I think so, yeah. I have to look it up, but quite a while.
Yeah, just darolutamide.
Yeah, there's nothing you can do about anemia except get off of these hormone drugs. Unless you're like super low, like Peter Kafka was, and then I think he had a couple of shots of Epogen, which is a red blood cell hormone stimulator. But they won't give you that unless your anemia levels are pretty severe.
Yeah, no, I'm not at that stage right now.
But again, this is really something that is more in the bailiwick of a medical oncologist. This is why we say you need a medical oncologist, because this is systemic treatment that is beyond the knowledge, and treatment is beyond the knowledge of a surgeon or a radiation oncologist.
Yeah.
So this is why you've got to get somebody who knows how to treat you systemically when you're on hormone therapy.
Yes.
And we feel strongly about that. Is there anybody else? Again, I want to move on. Is there anybody else who would like to just raise anything with John at all?
Yeah, this is Peter. I'm just curious, is HIFU standard of care? Did you select that, or did they recommend it? And is it covered in Canada?
Well, it's not covered. In fact, I had to pay about $20,000 for it, done at the Cleveland Clinic in Toronto here, where he rents space, and it is It is practiced by even
I know that, but it's not standard of care there. It wasn't suggested by the docs there. You had to select it.
I investigated options, and I asked these top surgeons who are top in their field in robotics as well, whether I was a candidate for the local treatment, and they all agreed. In fact, they have divisions of their own companies that will do that as well if I so choose. Now, if I had to do it again, would I do it? No, absolutely not. More so from the lack of follow-up, where you're kind of left to your own resources afterwards when they do that HIFU. You're not in a proper system like you are at Princess Margaret, where you systematically everything is checked on.
Again, yeah, I'm just wondering. That's it. Good.
Yeah. So anything else I mean, John, keep coming back here. You can see we've got a lot of knowledge about a lot of different stuff. And I know that it isn't strictly transferable, because I know that there's a lot of issues with in how you get treated in Canada. I have some limited experience. I do think definitely you should get your tumor sequenced. You may not have a high enough PSA level to warrant a blood test. It might not be effective at 0.19. I don't know how recent the biopsies are, but if there's anything they can biopsy to send off, especially soft tissue, if there's anything there. But Foundation Medicine Canada is the website, and they will subsidize you, because we've seen it. So they'll help you with the payment. The big issue right now is what they would analyze, and I wouldn't necessarily suggest using a sample from a year or so ago.
Yeah.
You need something as current as you can, and at 0.18, it's probably you're not going to get a result out of their blood, out of their liquid biopsy. Okay. No, but again, come back, talk to us,
yes.
And we can guide you next time on that. Mike Marino, I would like to just have you brief us quickly, and then I want to get into the intraductal, because it's very topical. There's 4 people on this call. John Garbin, if your prostate cancer cited intraductal, then what you're seeing right now is not unexpected. So I have some notes on you already, Mike. Why don't you tell the guys a little bit of just briefly tell them, or let me tell them what I know to save time, and then you can add anything. That Mike was amazingly referred to us by Jim, who, for those of you who have been not been around that long, he was a force in the field in Australia. He was known in this country, and he's sort of pulled out now, doesn't do a lot much more. And somehow or other, Mike in San Antonio found Jim Marshall, and Jim Marshall said, get hold of us. And so back in September, October, Michael reached out to me. He told me that he had intraductal 3+3, and he was getting a second opinion from Epstein. He started hormone therapy, and then he did some SBRT. And when I last spoke to him, he was considering a second biopsy. So why don't you tell us what you've actually done, Mike, and where you are right now?
Okay. Yeah, I went on ahead. I haven't had the second biopsy, but I did send my original biopsy to Epstein, and he upgraded my Gleason from a 3+3 to a 4+4. Out of the 12 lesions that I had, or whatever they did the testing on, of course they weren't all intraductal carcinoma. There were some that were benign. There were some that were just your normal endocarcinoma. Anyhow, I've since then my PSA has never been high. It's never been over 4.5. So I was a little confused with the diagnosis that I got. So that's why I did go to Epstein and try to get a little bit more information. And I haven't done any treatment yet. Early on, I started the bicamulotide. I did it for a month, and I was scheduled to do the Lupron. And for whatever reason, they didn't have it. It was backlogged. I don't know if it was destiny or whatever. I ended up not doing it, and kind of was still very confused and very unsure of how I wanted to go. If I wanted to do the radiation, or if I wanted to do the surgery, or if I was looking at alternative medicines. So where I'm at now, I actually, in between this time, and forgive me for jumping around, but I did have another, and this, I've had this diagnosis since May of 2020, so it's been about 17, 18 months. The last MRI did show that particular lesion had grown a little bit. So that did get, of course, worried me even more. And I said, okay, I need to do something. So we went on ahead and I started Lupron 2 months ago. And I'm leaning towards radiation now. I still haven't made up my mind completely. I went to MD Anderson in Houston because they had the proton radiation there in the spacer, which comforted me a little bit. I do live in San Antonio, so this has taken a toll on me mentally, financially, everything you can think of. I'm sure you guys can relate, but now I'm at the point where it's going to be difficult for me to go to Houston and stay there and go through the treatments there. Yeah. And have to afford the cost.
How old are you? How old are you, Mike?
I'm 55.
Right. So let me say a couple of things, because as it so happens, we've been spending quite a bit of time on this intraductal recently, and you've got another gent in this group tonight who's interested in what you're talking about. And Michael, it gives you an idea on how his cancer has moved since he was diagnosed. So you have a little bit of time. The advice that we gave to Michael, and I think we give to anybody, is that if you have intraductal, you need to get a genitourinary medical oncologist on your team to help you make the best treatment decision. And what I'm thinking for you, since it is going to be radiation, then you'll want to get treated in Antone and not at MD Anderson. I would strongly recommend that you make an appointment with Dr. E. Dr. E is Eleni Evstathiou. She was 14 years when you went to MD Anderson a few months ago. She was still at MD Anderson, but she isn't there anymore. She's moved to Houston Methodist. She's a really, really great genitourinary medical oncologist. And because she's not tied into the MD Anderson system, she can probably work with you once you decide on the treatment, to help you find a good radiation oncologist if that's what you decide. If she thinks that you're a good candidate for surgery, and given some of the issues that you've talked about, have they seen any lesions outside of the prostate yet, Michael?
No, my original MRIs and all the other scanning they did, there was no metastasis anywhere. Something came up in my colon, but I addressed it, and that was found to be negative as well.
Have they done a PSMA scan or an Axumin scan?
Not that I'm aware of, no.
And what is your PSA now that you've started the loop run?
Well, I just started it 2 months ago, but that short time, several months before that, when I did do that bicamulotide, my PSA went from 4.5 to about 2. And it stayed there for several months, but it did start to gradually go up. So the last PSI that I had I was down to 2.5, I think, but that was the result of the short period of time that I had the bicamulotide. But just to reiterate, I'm not going to be going to Houston because of the financial burden it's causing me. I've connected with a radiologist, oncologist in Austin, a CyberKnife facility there, a doctor Pelfrey.
But it's not the way to go, Michael. I'm saying to you, don't get treated in Houston. You don't get your radiation, but you need a quarterback. You don't have a quarterback, man. That's why you're all over the shop. And CyberKnife may not be right for you.
Well, it's very difficult. I'm getting different opinions from one radiologist says one thing and the surgeon says another thing, and that's why it's very hard to make.
That's why I'm sending you to a medical oncologist. That's exactly why I'm sending you to a medical oncologist. They don't have an axe to grind.
So they have any
insight? You go to the
on that?
surgeon, he's going to say, I want to cut it out. If you go to the radiation oncologist, he's going to say, oh, you should do CyberKnife. Maybe you should do CyberKnife, but I'll tell you what else. If it were me, I'd be doing radiation to the whole of my pelvic girdle, because I know that I've got a much higher risk of having lymph node involvement already at 4+4. So anybody who told you just to do CyberKnife, they're missing the boat. If you want to be around 5 years from now, you've got to get yourself the right quarterback. And the right quarterback is a genitourinary medical oncologist somewhere. And for you, that somewhere could be Houston. And you go to Houston, you meet with her, you or go back to MD Anderson and go see Paul Korn. But you taking yourself to this surgeon, to that surgeon, to this radiation oncologist, that radiation oncologist, that ain't gonna help you.
Okay.
So, if you want the best navigation, I'm not telling you to do surgery. I'm not telling you to do radiation oncology, to do radiation. I'm telling you, speak to somebody who knows so they direct you. And the fact is that if you were going to do radiation, the right radiation most likely, and you should be asking your radiation oncologist about this, is what about radiating the pelvic girdle? Are you going to radiate the pelvic girdle with your CyberKnife? I doubt it, because there are very few places in the country that do it with CyberKnife. So, and in the long run, I'm trying to save your money.
Rick, CyberKnife would not be appropriate to the pelvic girdle.
Yeah, that's not exactly true, because they're doing CyberKnife to the pelvic girdle at Carbone. But it isn't widely used. They're doing it in fractions in Carbone, but it's not widely used.
The reason I reached out to CyberKnife and back, that's why I'm saying I haven't really made a decision all the way, because that's why I'm here now, to get information from you guys. I know y'all have a lot of information, and I appreciate the information you're giving me. The reason I went to CyberKnife is because it is less sessions, and it would be shorter period of time, and I've read or seen or heard or whatever that sometimes it's better when you have a high risk or aggressive cancer. That may be true or not, I don't know, because you can't believe everything you read, of course.
Mike, here's the problem. You may need CyberKnife, but you need more than just CyberKnife. Nobody's saying CyberKnife is a bad idea, but you need more than that.
Okay, so I'm on hormone
radiation.
So
you need more than that.
Okay.
You need radiation across your pelvic girdle, across your hips, because the disease could be in your lymph nodes, and that's the way to get it. The radiation's the gluco's going to weaken it. But we're going to have to move on pretty much. But if you look in the window, the guys are all saying the same thing. Get yourself over to Dr. E. And she does televisits. Maybe you can do a televisit with her.
Okay, you said Dr. E. She's at what Baptist?
So hold on a minute. I'm putting it in. It's Dr. Eleni. Somebody else. Julian, would you stick a full title in for me? Dr. Eleni at Staffview at Houston Methodist.
I'm on it, Rick.
Thank you, man. Now, he is fantastic. She's a passionate, super smart doc. She's going to make sure you get the best treatment. She's going to be your quarterback going forward. I'm not saying we're getting an awful lot of feedback from you, from Mike. I'm sorry. I'm not saying that she is going to suggest you get treated in Houston with radiation. She may need. She knows doctors in San Antonio, I know. But she's going to be your main person. She's going to direct you, and she's going to give you the direction that you need. Do you just to close up, Julian, do you want to say a quick word about her since you're seeing her?
Yes, she jumped in after I had my radiation and agreed that all that had been done. But now she had me on Zytiga or Beterone. So my PSA in the last few months has gone down to almost undetectable, less than 0.1. But when we have conversations, we talk about everything. We talk about our, what's our blood work doing, and sometimes she'll prescribe additional or take me off of something. And I mean, she just follows me like a hawk. So if you're going to get a medical oncologist, I would highly recommend her.
You need that medical oncologist to guide you. Michael Chandler, do you want to say anything from what you've learned, or if you or Cheryl want to say anything about from what you've learned facing this intraductal to
Yes, thank
Mike
you, Rick.
Marino?
Yes, hey, Mike, intraductal out of some of my core samples from my biopsy, and I've followed what the group has said, and I'm looking forward to an appointment with a medical oncologist in a UC San Diego in 4 weeks, and tomorrow I'm looking forward to getting Dr. Epstein's pathology reports from Johns Hopkins, and it's a path, and thank you for your guidance and all. Thank you for your help.
So if you want the takeaway message, Mike, is try and get yourself an appointment with Dr. E, and she'll straighten you out here, because you're going to too many different places and you're hearing too many different things, and you've got to settle on one doc to really guide you. And she's not going to do the surgery. She's not going to do the radiation. she's going to tell you the right thing to do, taking into account your age, because that also complicates matters a little bit. Okay.
Plus, Rick, I just wanted to tell Mike to go ahead and come on the under 60 call as well on Thursday, and I can kind of help him get lined up with the finance side. Sounds like getting to places is an issue. You can do most of your meetings with her via a video chat. You don't have to travel to Houston. And like Rick said, she'll just help guide your treatments.
Okay, thank you.
Okay. I'm going to send you, Ken, I'm going to send you Mike's email address right now.
Make sure to add him to the under 60 group as well.
I will, yeah, I think he is, but I will try to do that.
I sent an on the chat. I sent an email out asking for y'all to add me onto that.
Okay, so I'll definitely check. So that's to Ken, and I'll send it to right now. I'll send it to Mike Chandler too, to Michael Chandler as well. All right, guys. Look, we're gonna have to work a little differently tonight. I'm happy to stay for another hour. Obviously, with 43 people still left on here, we had as many as 53. We just don't have time to poll. So we're going to have to figure out a different system today. And unfortunately, there's no hands up in here. Is there anybody? And as you know, we always poll, we always ask everybody. But if I ask everybody today, then I'm happy to stay as long as you want to stay, but you may not want to stay as long as that. So let me ask you, do you want me to poll everybody? I'm not hearing anything.
No.
Should we poll, or should I just ask who would like? Should I ask who wants time, and you can?
Maybe just.
Why don't we just
Maybe just to show. Why don't we put stuff in the chat window if we have an issue?
Rick, I'm suggesting maybe people could put in the chat window if they want time.
Yep. So why don't you put it? And John Ivory has a great suggestion. Is there anybody facing a decision between now and next week? If they are, put your camera on and put your hand up. So there's nothing that pressing if we didn't talk to you till next week. Okay, that's good. Are we sure? Nobody needs immediate information. That was a great suggestion, John. Secondly, if you want Fred Stiers, any recommendation for a good medical oncologist in northern New Jersey? Fred, first of all, let me say this. I know you're new. We just can't handle another new person this week. Come back to us next week. Come back to us next Tuesday. Peter Kafka will be chairing. He'll let you he'll give you priority, and we have a whole number of recommendations. They're not in Jersey. They are all in the city. Here's what we know. We've got a couple of people at New Jersey Cancer. How good are they? Not sure. The gent who uses them has left the call already. If it were me, I wouldn't go there. If it were me, I'd go to one of the facilities in the city. And we've got guys who see docs in the city at Mount Sinai, at Memorial Sloan Kettering, at Weill Cornell, and we can certainly talk to you about all the docs. but I'd rather take questions right now from people who are returning in case there's anything.
Thank you, Rick.
And why don't you?
Please put me on the notification list as well, okay?
I will. Do we have your email?
Yes, you do, sir.
Okay, I will make sure to do it, and please come back next week, okay?
Be glad to.
Next
Thank you, Rick.
week's session starts at 6 o'clock Eastern, not 8 o'clock. So it'll be 6 o'clock Eastern, the regular session on Tuesdays. Tuesday sessions start at 6 o'clock, and you'll get a reminder. Ken, why don't you take some time?
Just stepped away, but I don't really have much to say other than I went ahead and signed up for more sessions. So gonna get a PSMA PET scan, the Polarify scan on the 10th, and then another on the chemo. And whenever lutetium gets approved, and Len's comment was absolutely true. Paul's always stated that lutetium is great, but it just isn't remarkable in longevity. So maybe I'll start, lutetium when it's approved. But for now, a cycle of chemo seems to be holding my PSA. But, it's all good. Any questions on chemo?
Mm-hmm. Well, where's your PSA? Give us an update on how it's holding your PSA.
Well, honestly, I think dexamethasone influences chemo's effectiveness. For 4 rounds of docetaxel with adding, additional dexamethasone over the 10 milligrams, my PSA didn't go down, but went up a little bit each cycle. And then when I went off dexamethasone, the extra, it gradually went down. So maybe it's only for me, because I know they give this stuff when you get chemo to support the chemo crash. But my PSA was just pulling up my graph because I don't really try to, memorizing such things when you've had 30 plus rounds of chemo is pretty difficult. It's like 43, but I'll tell you in 1 second. Give me I know you guys are consuming time. Sorry about that.
No,
I wasn't
okay.
prepared. Wasn't prepared.
It's okay. People want to know about you.
Okay, graft. Funny thing is, this is the first round where my alk phos is lower than my PSA. Alk phos actually not lower. Alk phos is 43. PSA is 43. Testosterone.
That's really good.
I would think my alk phos, it's always been, alk phos has always been, running parallel with PSA. Whenever it went up, my alk phos went up. This is the first time that they're kind of switching places. My LDH is really low, so Paul's not too worried. Yeah, I don't know. Might even continue on chemo even when lutetium gets approved until they work out the bugs. So that's about it.
I have a note that your alk phos was at 43 back in your PSA was at 43 back in October. So as you say, it's really holding you, eh?
Yeah, it went down to 40. So it went 28, 36, 43, 40, 43. It's bouncing around. It was in the 20s. Now it's in the 40s. Paul and I's, our goal is to keep it under 50 by year end, and we did. So I guess if there was another mile marker, it would be 75 by the end of 2022. Yeah. As long as I can continue to, keep my blood in line, honestly, that 3-point drop, I was probably hiking, 7 to 15 miles a day while I was in Maui. And I gained 7 pounds that 2-week period. So exercise definitely helps. Mobility is key.
When you say you gained 7 pounds, is that
I'd lost.
or is that...
Yeah, it's a good thing because I'd lost 10 pounds. Yeah, only because with so many chemo rounds, I don't really have an appetite.
Right. Okay.
That's about it.
Yeah, and so let me throw it open to the guys. I'm sure some of the guys want to, if nothing else, offer their support.
I do.
Yeah, I
You
did.
already know this, but I want to be like you when I grow up.
We already are, Jimmy.
Pure and simple, man.
Yeah, I must admit, I think I'm more of a freak.
That's the kind of freak you want to be in this life.
At the moment.
Look what you've done. Look what you've done, and you controlled what you could. That's what impresses me the most. So much out of your control. What's in your control, you've tended to, and it's had everything to do with the results, I think.
Well, thank you.
You're welcome.
Who else wants to speak up? Anyone?
Well, I'm looking forward to jumping onto lutetium whenever it comes available, as long as it's readily available.
So how many are you at right? How many chemos are you at right now?
32.
32. Oh my gosh. Okay. And in the second session, we need to add.
Yeah.
For those who don't know you, this is the second time around, but 32x. Fantastic.
So,
God bless.
Yeah.
Over what period of time, Ken? How long? How many months?
Gosh.
Or how long?
I started out at 3-week sessions, and I'd asked Paul like 6 cycles in if I could extend it to 4-week sessions to buy me additional week. So I get chemo every 4 weeks now, and that means I get 1 cycle every month and have a 3-day crash after the dexamethasone wears off. And that is fine by me.
You are the man. You are the man.
Yep. What is an ideal alkaline phosphatase level?
Well, I'm always low. It'd probably be closer to 70. Is that correct, Herb?
I think it's more like 55.
Oh, I'm corrected. So I'm happy mine's low. Not a lot of bone activity, even though I have a lot of mets.
Well, I think the height might help,
Absolutely. I don't think I know, So.
Did you say, Ken, that you're scheduling a PSMA scan?
Yeah, it's scheduled for the 10th. I've asked 3 times what's it's going to cost me because, again, I just started my new cycle, and I'll be damned if they can tell me.
Is this a Pylarify that you're going to get, or
It is. Else? Yeah, we're going to compare the Pylarify to the Oximum in October to see how much expresses PSMA.
Okay.
So that'll be ready to do lutetium if, in fact, a majority express PSMA.
Yeah. I think you qualify on the basis of having done chemo.
I don't know. If 50% express PS, I don't know if it's going to be just fingers crossed that 80% or more express PSMA.
Right. So when they do the Pylarify, they're going to do a bone scan, a technetium at the same time to do the comparison.
No, I just had a technetium in October.
Okay.
So we're going to compare to that one. Okay. There was no radiographic progression from April to October. Paul's thoughts are there probably isn't. So what? Yeah.
That's great. That's great. All right. who else would like to take some time tonight? The floor is open. No one? We should do it this way every week, guys. Nobody wants to speak.
Rick, I think we're all exhausted for 2.5, for nearly 3 hours.
Yeah, I think you might be right. It's also the reason why we ask you individually, because we know that when we ask you individually, we get different answer than if we say who wants to speak. This is a perfect reason as to why we don't say who wants to speak. How about Don? How about John Du Bois? Are you still with us? I don't see you here. I know you're local here in Tucson. Although I think your issue was really more for Peter's group. When I think about it, I think you were looking for, I think you were really for Peter's group rather than for this advanced group.
Joel was going to say something before.
Yeah, Joel, you were gonna update us. Take the floor, man.
Yeah, I just tried to a minute ago, but it failed. Anyway, back to my radiation oncologist. When I went to Johns Hopkins, the first thing that Denmead said to me after his doctor had taken a physical of me, and he had seen my PSMA PET scans, as I reported back a few months ago, is that we don't know how to read PSMA PET scans here, and because it was the first one he'd ever seen, and so then his underling ordered an MRI for me. Well, I don't know how you order, I don't know how a doctor orders an MRI and how many types of MRIs there are, but I suspect the machine might have been a 1.5 Tesla as opposed to a 3 Tesla, because my radiation oncologist ordered two MRIs, one for the T-spine, one for the C-spine, and he was very happy with the results. He called me today and said, very glad that we took the MRIs on you. I'm sorry it took over 2 hours, but he says, I ordered an extra fine resolution on the MRI. That's why it took so long. I didn't know you could do that, but I know my machine was 3 Tesla because it said so in the report. So he says he was very happy with the occipital condyle bone pictures, and he knew exactly how to radiate it now. And so I'm going in tomorrow to get my mold done. But it appears that the mistake was made at Johns Hopkins, where they ordered just a regular old MRI, whatever that means, instead of a super sensitive one. And so, because I was only in the machine at Hopkins for, I don't know, 40 minutes or less. So it was a different MRI, obviously, than what the radiation oncologist gave me. So I didn't know you could up the sensitivity of the MRI. All that does is means you're in the machine longer. So that's all I wanted to say.
Okay, so when are you starting? When do you think they'll start the spot radiation?
They'll do that the last week of January. It takes them a couple, 2.5 weeks to plan it out. And he's even bringing a neuro guy in there as part of his planning team because it's close to the brain. So so he's confident that he could angle that CyberKnife machine at the right angle so he doesn't hit any vital parts, including my spine. So he says it won't be any problem at all, but radiating is something that he doesn't want to radiate. So my treatment, they'll give me my schedule tomorrow. They'll give me exactly what 5 sessions. He's going to do 5 sessions of SBRT with a day in between. So that's in 9 days I'll have it done. But they won't start till the end.
And where are you? So I'm confused now. Where are you going to do this? In the military hospital or at Johns Hopkins?
Neither. I'm going to do it in Virginia at the Loudoun the Loudoun County Hospital, where this doctor practices, along with he also practices in Fairfax County at the Inova Shar Center. So
right. And what's his name, the doc?
Dr. Eblen, E-B-L-A-N, and he E-B-L-A-N again, and Dr. Antonucci loves him. So
okay, good.
Yeah.
Okay, well, if he's recommended by Dr. A, he's good enough for all of us around here.
Yeah.
And you, no doubt. And
Oh,
you.
yes. Yeah, and the second PSMA that I took proved that he had killed my cancer in my left iliac bones. I was very happy with it.
And now, is Eblen a guy that specializes in like skull radiation and brain radiation, or is he a GU? He's not a GU radiation oncologist.
No,
is he?
he's just a radiation oncologist, but he does all types of radiation, and he just so happens that he's done a few skulls, just because the cases came to him. But I got the impression he's done 4 or 5 brain cancer type radiations already. And as I said last week, I think the brain radiation, brain cancer is usually in the fluid between the brain and the bone,
Right.
not actually in the brain.
Yeah.
Oh, it
And we
depends.
spoke
What
to
it
somebody.
depends on the cancer, Joel.
Yeah, I'm talking prostate cancer. Yeah.
We spoke to somebody recently, maybe one of you, my moderators, can help me, who had cancer in that same area, and they said it was too close to the brain to radiate. Does anybody remember who that was? Does that conversation ring a bell with you guys? No.
I remember it, but I don't remember who it was.
Yeah, I recommended looking into proton beam because of the issue of the brain.
Yeah, that's right. Who was that, Peter?
I'd have to look at my notes. I don't have it in front of me right now.
Yeah, because
it was last
I'd
week,
like
though.
to. It was last week, wasn't it? We'll have to look. We'll have to look.
Len, do you have notes on that?
Well, I'd have to go back and look at my written up notes in the. I need to look at my written up notes for the meeting. I don't keep handwritten notes. I keep notes on each person, but I don't know who the person is. So I don't. I know what you're saying. No, I don't keep notes that way. All right, guys. Look, it's been a long session because of the hour start, which was outstanding. And thanks to the moderators and the participants who jumped in there, and will be doing the same thing in 2 weeks. Sorry that the rest of the meeting has been a little disjointed, but we had a few important things to cover this time. And I apologize to if there are any returning people who need to discuss something. Don't hesitate to email me or one of the other guys. I shouldn't volunteer their time. I can volunteer my own. But if there's something that's on your mind, please let us know. If it can't wait till next week, if it can wait till next week, we will be back next Tuesday. And I think that's about it. Anybody got anything else they want to bring up tonight, other than to be released from this meeting? One thing I will say later on this week, we have our young man speaking freely. If you know any young men, and by young we mean roughly 18 to 45. If you know anybody living with a chronic condition, whether it be cancer or MS or anything else, we've got a meeting specially for them to support them on Wednesday. And again, write me. I'll give you more information on that. If you want to tell anybody about it, it should be a really good meeting. It's modeled on our Speaking Freely meeting, which is the third Thursday. That is open to any men with any type of cancer. This is even wider. This is any chronic condition, because we recognize a lot of younger guys don't get the support that they need.